I'll introduce the second speaker. Dr. Diane Kelly is an intensive care specialist at Epworth, Richmond and Royal Melbourne Hospitals. She's also senior lecturer for Monash Medical School, working mainly... Picking up her phone, on curriculum development for patient safety teaching. She has a special interest in optimizing assessment within medical training, as well as the delivery of multidisciplinary medical education. And Diane's going to talk to us about using impromptu in situ simulation to evaluate a training program.
Hello, I'm Diane. Thanks for letting me speak. So a wee bit of a change of direction of topic, and I'm going to talk about a little research project that we did at Epworth Richmond. So Epworth Richmond is a high-volume cardiac centre, and we do a lot of in-house training specific for cardiac surgery. And one of the things that we do annually is ALS specific to the post-cardiac surgery patients, otherwise known as CALS. So we wanted to evaluate how effective our CALS training was. And to do that, we did a single-centre prospective feasibility before and after study using in situ simulation to assess clinical performance after CALS training. So I'll go into just a little bit of detail about why we chose that method to evaluate our programme. So within modern multidisciplinary medical education, we use a lot of skill-based courses to try and achieve competencies in certain areas. And in fact, a lot of these skill-based courses are actually mandated by institutions or by training colleges. But the question is, just because we're doing the course, are we actually achieving the competency? And in terms of evaluation of education, the gold standard is looking at patient outcomes. But by definition, a lot of what we're training for in intensive care, they're low-frequency, high-consequence events, so they don't happen often. And the negative outcomes from these events happen even less frequency. So the outcome of the patient outcome really, as a measure, becomes infeasible. So then you have to think about, well, what else can we look at? Well, the next best thing might be just looking to see if the skills translate to clinical practice. So let's have a look at real-time performance. But then again, they're low-frequency events, and they are often time-critical and unpredictable. So real performance becomes, again, an infeasible measure of assessment. So then we can have a think about, well, what if we could just make these events as real as possible? What if we could mimic them so that they felt real, but we can control how often they happen and when they happen? And that's when simulation becomes an invaluable tool. And the two really important aspects of this form of performance assessment, you need to think about the key elements of simulation, and you need to think about the performance tool. How are you going to measure that performance? So thinking about the key elements of the simulation, I think the first thing is it needs to be high fidelity. And what we mean by that is it needs to feel real. And probably the most important aspect of this is actually doing it in the unit. So there's nothing that makes a scenario feel more real than using the machines that you normally use, having the sounds, including all the background sounds, all the background smells, good old Melina. It makes it feel real. And it makes it feel much more real than any kind of high technology mannequin could ever do. It should be immersive, so not interrupted, unannounced, as a real event would be. And you should utilize the unit's own equipment and protocols. So if you have a resternotomy trolley, then you should use that very resternotomy trolley for that particular simulated scenario. And as I mentioned, the simulated event can happen as often and whenever you want. And I think the other important aspect to think about is that you can actually observe the key thing that you've trained. So if you do real-time performance and you think that there is a patient who is proceeding to arrest post-cardiac surgery, you might not actually perform a resternotomy. You might get ROSC before that. And if it's resternotomy that you're assessing, then you can't. Whereas obviously with the simulated scenario, you can control the scenario such that it definitely proceeds to demonstrate the key skills that you've taught in the course. And also the assessment standardized. Everyone goes through the same scenario. Everyone has the same assessment standard. And then thinking about the performance tool, it's really important to think about what are we actually measuring and how are we going to measure it? How are we going to develop our performance tool? And so I think there's some important things to think about when you're making a performance tool. And the first point to make is you should try and include aspects of performance that have already been proven in the literature to improve outcomes, so that you're extrapolating as effectively as possible to patient outcomes. So for a CAL scenario, you probably want to include time to internal cardiac massage, because that's what the body of literature has documented. Less than 300 seconds, there's better outcomes. You want to include key skills which are specific to the successful management of the event, such as troubleshooting for a minute before doing CPR in CALS. And you want to include key management decisions that will lead to the definitive management of the patient. And for example, in CALS, it's essential that you call the cardiac surgeon because the definitive process will be getting the patient to theatre and fixing the problem. So just back to a little bit about what we did. So we used this high-fidelity, immersive, unannounced simulation, and we performed a before and after study. So everyone went through the scenario pre-training and then 2 to 4 weeks after the training. So again, not immediately after, because you don't want retention of skills. We're assessing translation of skills. The groups that we assessed were in kind of doctor-nurse ratios reflective of standard practice. And we videoed the scenarios and then marked them from the videos. Our primary outcome was feasibility. This is a fairly new mode of assessing an educational intervention, so we wanted to see it was feasible. So we measured total cost and staff time. And then secondary outcomes were performance before and after. So we developed via Delphi methods, using nurses and doctors within the unit, a performance assessment tool. And the score of that tool out of 17 was actually ideal performance. So we defined what we thought the ideal performance should be, and we marked against that. So a little bit more about the performance tool. As mentioned, we actually looked at the management of the event, so not the individual performance, it was team performance. We included time to internal cardiac massage, as mentioned before. We included other breakdown of that time. We looked at specific times within that time, so that if there was a delay, we could identify trainable areas. Time to call cardiac surgeon was essential, and we developed a point system to mark the key skills that were essential for successful management for ideal performance, and that was out of 17. So that our overall tool measured performance against the standards, gave us a score which reflected ideal performance, and identified key steps and skills which we could target in future training. So in terms of results, it demonstrated feasibility. So the equipment cost, although expensive, was the same equipment that we used for the training, so it wasn't an additional cost. The main time was spent in the planning, and that was one-off. So the actual time that we used for each repetitive scenario was actually very small and very feasible. And then in terms of secondary outcomes, time to internal cardiac massage markedly improved, such that everyone was below the 300 seconds post-training. The performance score, which was pretty dismal to start with, actually improved markedly, and some were actually achieving that ideal performance of 17. And interestingly, time to call cardiac surgeon, although better post-training, the fastest time was slower. So that is certainly something that we might need to target in future training. So this method was feasible. And in fact, in terms of secondary outcomes, there was a significant improvement in both time to internal cardiac massage and performance. So it may well be worthwhile exploring larger studies to evaluate CALS training. And then just a little bit about future things to think about. Two important things. You control the scenario, so you can assess what you think is important within the performance. If you think troubleshooting is more important than resternotomy, you can create the scenario such that if troubleshooting is successful, you get ROSC. And then secondly, you don't need to use this technique purely for skill-based courses. It could be applied to a unit to try and identify areas that require training. It could be applied to a training program to assess competencies of trainees, or indeed to an exit exam to assess competencies. And that's the end.
Thank you very much. Any questions? There's one at the back.
How many training sessions did they undertake? How many groups were assessed, were filmed?
So we did, I think it was 10 performance assessments pre, 10 performance assessments post. And the groups were linked by the team leader. So the team leader in each were compared, but the rest of the groups might have changed. So it was quite small, but it was significant.
Any other questions? Anyone? Thank you very much. Well,
Thank you.